you everyone for coming. For those who don't know, my name is Claiborne, and for the past 16 weeks, I was out in an outpatient pediatric clinic in Virginia Beach, Virginia, working with Children's Hospital, the King's Daughter. So a little bit about my patient. She is a 14-year-old African-American female who was referred to physical therapy in September 2016. She was diagnosed prenatally with ring 13 syndrome, and her newborn testing showed neonatal karyotype with a 13q34 to determine installation of the ring. So in a little bit, I'll kind of tell you what all that implies. Her comorbidities included a mild scoliosis, a possible mild leg length discrepancy, ADHD, intellectual disability, and PMDD, or premenstrual dysphoric disorder. So a little bit of a background. Ring 13 syndrome is a genetic anomaly in which chromosome 13 forms a ring at its breaking point. So the chromosome itself breaks and comes back to form a ring. And then there are deletions of the chromosomal segments distal to that breakage point, and the break can happen in various areas on the chromosome. Ring 13 occurs in approximately 1 of every 58,000 live births and is more common in females. Some typical presentation of ring 13 is the intellectual disability, CNS anomalies, facial dysmorphism, microcephaly, hand and foot abnormalities, and internal organ abnormalities, as well as ambiguous genitalia, and then the global developmental delay. So according to Woods and Bastow, microcephaly is a clinical condition that's characterized as having a smaller brain than the mean for sex, age, and ethnicity, with the occipital frontal head circumference of equal or less than -2 of the standard deviation. So additionally, what my patient had was the 13q34 deletion, and that has been linked to the F7 gene encoding hematological factor as well as factor 10, and those can have an effect on the clotting times. However, this was never reported in any of my patients' medical history as being an issue. So here's just a chart of some of the signs of ring 13 in general. The ones that were most prominent in my patient were microcephaly, intellectual disability, stunted growth, facial dysmorphism, a broad nasal bridge, and a protruding forehead. And so at this time, I just kind of want to paint a picture of my patient to you guys. She had a very, very significant cognitive delay. She had difficulty following direction. She had difficulty with communicating. But she was just the sweetest little girl in the world. She always wanted to please. She didn't know a stranger. She was really happy. So this kind of leads me into the purpose of my case, which is to highlight the challenges of meeting physical therapy goals in a patient with microcephaly and significant cognitive impairments. I wanted to determine intervention and communication techniques that were successful in order to implement those in further interventions with this patient, but also be able to apply those to patients in the future. So the initial examination was performed actually by another PT in December of last year. She was evaluated using the BOT2, which I'm gonna botch this, but it's the Brunick-Ostrowski test of motor proficiency, better known as the BOT. So only 3 subsections were actually completed during the initial evaluation, and she scored well below average on all of the sections. She also demonstrated difficulty with ascending and descending stairs safely, standing on one leg for about 1 to 2 seconds per limb, and required 1 handhold assist on a balance beam, and just overall poor safety awareness that was most seen when she was on the swing. I do want to note at this point that range of motion measurements were not taken during the initial evaluation. So a little bit about the BOT. The BOT has 4 sections, and then each section has a subsection. The 2 that were performed on my patient was the body coordination and then the strength and agility. So the protocol for the BOT allows for 1 demonstration of each item and then 1 practice session of the item before it is formally scored. There is research to show that this is one of the most widely used measurements for patients with intellectual disability, cerebral palsy, autism, and developmental coordination disorder. But there's also research to support that this should actually be looked into a little bit further because of the ambiguity between the raw scores and then the scaled scores for children with intellectual disability. So that will kind of play into my clinical reasoning further down the road. So to apply this biopsychosocial application as we do with all patients, there were some things that were really going to play into my treatment with this patient. So obviously the Ring 13 syndrome was something I really had to consider, but also the ADHD and the intellectual disability. And mom had questions about whether or not the premenstrual dysphoric disorder was playing into that. So I will kind of talk about that a little bit later. Her personal factors: she was a daughter, she was 13, she turned 14 while I was treating her. She had good family support. Mom attended every session and came back into the PT gym with us. Like I said, she was really happy and motivated. She wanted to please, so she was going to complete anything that I wanted her to do. I also had to keep in mind that she did have an IEP. She was receiving speech therapy at school, and she was also an adaptive PE. So for the long-term goals, those were established by the evaluating PT. They wanted for the patient to walk across a 3-inch wide balance beam independently, to descend 20 steps independently with an alternating gait, which is 1 foot per step. And then that the family would demonstrate independence with the HEP prior to being discharged. Some short-term goals: that she would be able to jump forward 24 inches, which is something that a 13, 14-year-old should easily be able to do, but she was not able to do at the initial evaluation. Another stair goal, but then also running and stopping within 3 steps, and this is a component of the BOT that she was not successful with on the initial eval. So the plan of care was established for 1 time a week for 60 days, plan of care through February 5th. The intervention plan was to mainly focus on balance interventions, as well as core and lower extremity strength. At this time, it was determined that the mild scoliosis and the possible leg length discrepancy were not significant enough to be impacting her function, and therefore were not a focus of this plan of care. The expected outcome for her improved balance and ability to safely perform independent activities was pretty good, based on that mom was coming back into the sessions and seemed to be fairly involved with her other therapy at school. So that was the prognosis at this point. So if there are any questions about the initial exam, I can take those now.
What was the initial reasoning for her to come to the
So the physician had referred for balance, strength, and coordination. Those were that was the focus.
And she had PT prior to
I think she had PT in school before, and she's not currently receiving those services. Okay. So moving on to the interventions, we focus on the core strength, the lower extremity strength, and balance and coordination. So some of the interventions that we did for core were, we have this long linear swing in our PT gym, and we worked a lot on having good posture, really engaging those core muscles, and varying the level of upper extremity assistance that she was allowed to use, either holding on to one side of the rope or placing her hands in her lap. I think it's important to note that at this point, she wasn't able to push the swing herself. That was more of a cognitive limitation than it was a physical limitation. She just didn't really understand how to move legs back and forth to get that swinging sensation. So I was with her on the swing to do that. We did a lot of activities in a Taylor sit, which is crisscross applesauce. We did a lot of reaching overhead, outside of the base of support, trying to engage those core muscles again. She frequently, especially at the beginning, was really trying to use one hand to support while I was trying to have her reach. And I found that placing her hand in her lap was a more effective technique than trying to tell her, oh, please, like, don't use that hand. Lower extremity strengthening, we worked a lot on the scooter board, so she would sit on the scooter board and complete activities where she had to propel herself with both legs. We did a lot of stair climbing to work on that stair goal, and then balance and coordination was walking across the balance beam and then walking on various surfaces. In the PT gym, we have lots of mats on the floor, and transitioning on and off those is really good for challenging balance. So at my clinic, we perform what are called plan of care updates. And so essentially what this is a total reevaluation of the patient at their short-term goal dates. So I performed the first POC update on January 23rd and extended her POC through the middle of April. I had found research that said children with intellectual disability tend to need longer periods of intervention in order to really see progress with their gross motor skills. And then I performed a second one towards the end of March, and that was because I had set new short-term goal dates for her. At this time, I changed some of her goals based on what I had seen with her. I discharged the running and stopping in 3 steps goal. I felt that that was not something that my patient was really cognitively able to understand what we were asking, and therefore I was kind of setting her up for failure because I didn't think she would be able to achieve it. I added a continuous play goal for improved endurance. In the first couple of weeks that I worked with her, I noticed she was really short of breath after just a few activities. We would have to sit and take a break. And then I also added a goal for reciprocal ball play skills, focusing mainly on throwing and catching, what she was having trouble with. I felt this was a really functional goal because she wasn't an adaptive PE, and that was something that she could kind of transfer over to her education. So also while I was performing these plan of care updates, I really wanted to assess her range of motion formally since it hadn't been assessed at the initial eval. I had noticed that she was definitely limited in her hip flexion, and I felt like maybe that was contributing to her difficulty with reaching forward and outside of her base of support. Mom had also mentioned to me that she felt that her legs were stiff, and so she wanted me to kind of incorporate that into our treatment. So here are her range of motion at our first POC update. I do want to note that my patient did not like having to be down on the mat and out of not playing, so I'm not so sure that they're super accurate because I was trying to kind of fly through them, and there were a lot that I missed at the first one. So I kind of take these with a grain of salt, but I definitely noticed some limitations. And so here was the second round that I did at her second POC update at the end of March. I was able to get a little bit more, but I was noticing they really weren't changing the way that I wanted them to with what we were doing. So after the updates, I added some interventions. I added reciprocal ball play into each session, working on throwing with verbal cues for attention to task, and then catching with assistance that ranged from standby assist to hand over hand assist, just kind of depending on our attention that day. I added dancing at the end of each session for endurance, but also for motivation. My patient loved Beyonce, and who am I to say, no, you can't dance to Beyonce at the end of each session. So I also instructed the parents, mainly mom, she was the one who came, but dad did come to one session. So we incorporated some lower extremity stretches for her hip extensors to work on that hip flexion, so just single knee to chest. Hip flexors, so I encourage playing in prone, and then just your typical 90-90 hamstring stretch. And then I added endurance challenges with decreased rest breaks throughout the session, as well as walking on a treadmill. So some other factors I really had to consider with my patient. She had significantly increased urinary frequency. This was something that mom had expressed to me from day one was a huge challenge for them and something she had been trying to seek help from physicians with for almost a year. I was able to document this into all of my notes to show just how significant it was. She was using the bathroom between 3 to 4 times every 55-minute session. So that really kind of broke up our interventions a lot. And I assured Mom that because she was part of the Children's Hospital of the King's Daughter network, that any of her healthcare providers were able to see my notes to see that this really was something that was disrupting their daily life. Something else I had to consider was the cognition and attention to task were very difficult for her. She had that significant microcephaly as a result of her syndrome, which has been linked to a severe impact on motor development and motor performance, and then that overall cognition. So she struggled with following directions. She really had a hard time with mimicking any type of movement. Mom said that had never really worked for her. And she was really easily distracted to the point that my CI couldn't be visible in the gym with us because all my patient wanted to do was look at my CI when she was in there. So another comorbidity that we really had to think about was this difficulty with communication. Not only did I have to reevaluate how I was communicating with my patient verbally and non-verbally, but the communication that she was giving to me, I really couldn't understand. She scripted a few phrases that were like very clear, but other than that, when she was communicating with me, I really had to look to Mom to say, I'm not really sure what she's trying to tell me. And although they usually didn't have any significance as to like, this is hard or anything that we were doing with the intervention, that's really important for patient rapport and building that relationship. Something else that I wanted to consider was whether or not the premenstrual dysphoric disorder was having any effect on our ability to progress in therapy. So premenstrual dysphoric disorder is a medical diagnosis. There are 11 signs and symptoms, and in order to receive the medical diagnosis, you have to have 5 present. I don't know which 5 my patient had, but she did have that medical diagnosis. Mom had told me that she felt that when the patient was menstruating, that her balance and coordination just seemed a little bit more off during that week. Mom herself reported that she even felt that way, just a little bit uncoordinated. So I wanted to find research to see if there was a correlation. I could not find anything that supported that, but I do feel that if the ones that were underlined were ones that my patient was symptomatic with, then it would make sense that if she had difficulty concentrating or lack of energy or joint or muscle pain, that she would be a little bit off during that week. So on the final treatment session, I had a few things that I wanted to think about. The first was I going to use the bot to reassess my patient, since that was used in the initial eval? I decided I was not going to, because after getting to know my patient really well for about 4 months, I knew that she really was not able to mimic any of the movements that are in the bot, and so I felt like that wasn't going to be an accurate representation of her physical ability. And then I also noted on the last day that she did have increased tripping and loss of balance at this visit. I talked with Mom. Mom mentioned that she was menstruating at this time, so she was still trying to make that connection with the PMDD. So because of that, I decided I was not going to discharge her at the state, but I moved her to a consult status, which means that she was not going to be receiving therapy every week, but if Mom saw like a decline in her function, then she could call and get an available appointment as soon as possible. So was there progress made prior to discharge? Absolutely. So her balance beam goal, she was walking with standby assist on a 6-inch wide beam and varying from contact guard to one-hand pull assist on the 2.5-inch beam. She was able to ascend and descend 20 steps independently with that alternating gait, but she was using 2 hands to do it, or 2 rails to do it, which I was fine with because I didn't really want to encourage that lack of safety, since she was already having issues with that safety awareness. The family had met the goal of being independent with their AGP prior to discharge. For the short term, she was making progress with her jumping. We were getting about 18 inches pretty regularly, but we never got up to the full 2 feet. And she met the goal for the 20 minutes of continuous activity. She was actually able to complete 55 minutes without any scheduled breaks, but I do keep in mind that she was taking those restroom breaks as needed. So just a few final thoughts before we head into our questions or discussion. I really wanted to focus on what worked, what didn't work with this patient. So things that I felt really worked were that repetition of using kind of the same cues and everything to see if that made a difference, if she was better able to understand. And I did feel like that worked because in the beginning, she had no idea what I meant by crisscross applesauce. Mom was like, I'm not sure if she's ever heard that in school. And by the end, she knew. We sat down, I'd say, okay, crisscross applesauce, or if she wasn't in that position, I could tell her and she would fix her legs. I felt that the tactile cues for upper extremity placement seemed to work the best instead of verbal cues, even if I kept them consistent. And then I had discussed with Mom as far as other hypotheses that as we kind of reached a plateau in therapy, that I felt that some of her balance deficits weren't true deficits as far as a physical therapy standpoint. A lot of it was inattention to task and just being very distracted and not paying attention to what she was doing. And Mom seemed to agree. If I could do anything differently, I probably would have picked a better outcome measure to use. I was kind of interested if maybe there was one that really did seem to work better with children with intellectual disability. Of course, I would like to have performed the initial eval on my own because I hadn't seen the patient for really the first month to get a good, true baseline. And then also I would have liked to encourage Mom to be a little bit more involved in our treatment sessions and maybe a little bit more compliant with things at home as far as the stretches and everything. So, there's some questions. Yeah.
Did Mom or Dad say that they had to do with anything at home with her other than just the balance stuff?
It was mainly just like balance. They just felt like she tripped and would fall a lot more than like a typical child her age. So that was their biggest concern.
I would miss it, but instead of the bot too, did you use another?
I didn't.
Oh.
I couldn't really find one that we were using in our clinic that I really felt was going to be a good representation of what we had done. And I feel like a lot of the pediatric ones are so based on, can you follow this direction? Can you do what I'm doing? And I knew that my patient couldn't do that. Amber.
Was she on any medication for her ADHD?
She was on 8 months of medication. It was just, I was seeing her at the end of the day, so it was after school. I saw her at 4 o'clock on Mondays, so I feel like that played a large part on, we weren't really fully medicated at that point.
Do you know what happened as far as like the urinary frequency and that was all up?
I kind of kept talking to Mom like throughout the 4 months, and she said right before I was leaving, she had a doctor's appointment. I don't think it was with the urologist, but I think that it was someone that they were hoping was going to refer them to urology. So there was progress made, I think.
How did you effectively like communicate with her and build a relationship if there was the cognitive deficits and communication barriers?
So a lot of it was the like scripting, like she really didn't know a stranger, so it wasn't terribly hard, but it was just a she was familiar with me. And so it was just like, we could talk about things, but there wasn't always that response, or if there was a response, I always had to look to Mom to be like, okay, what did she really say? So there was communication, it just wasn't always effective or like a natural flow as you would want.
And just I know you said, and you did this over the specific goal, but like a continuous play goal. So how did you write that, or like what were your parameters for continuous Based or?
I can tell you because I have them. It was essentially that she would play for 20 minutes without a rest break, without visible signs of shortness of breath or any undue fatigue. So like if we were just, the reason that I incorporated that was the first time that I saw her and we did scooter board. We did one lap and she was just like, her respiratory rate was like super high and I was like, whoa, like this is way out of the norm of what I would expect for a child of 13 to go like 170 feet.
Yeah, I just didn't know if you then specified, like on the scooter board or a standing position or, you know, I didn't have a sense of what's more aerobic play versus just stationary play in a position.
No certain position, and I don't think I like specified it, but I guess in my mind it was more like, it didn't count if we were like sitting down doing a puzzle and reaching. It was the like, are we up? Are we moving? Things like that. Amber.
Did you feel that one time a week was enough?
I
Or do you feel like you could have gotten more out of her?
don't think I could have gotten more with more than one time a week. I think that maybe if we had encouraged mom to be a little bit more involved, then maybe we could have. But I never really considered going up. I didn't think it would help.
What was your like biggest aha moment? Like what's your biggest takeaway from working with her?
I actually think that my biggest like aha moment was that no matter what, like this is still a child, and even though there were like a lot of barriers, it was still just like I had to make it fun, I had to make it a game, and even though if she didn't understand what I was trying to have her do, as long as she was having fun and we were kind of getting what I was getting at, then I was happy with that.
Challenge for your job. Yeah, thank you.